Hello? Hello, everyone. I'm Mark DeAntonio, and thank you all for coming today. One is, as you see the slide in front of us, that I have no disclosures, and that the format we're going to do is I'm going to start talking in a few minutes, in somewhere around 9:45 to 10, and during the talk, participants can type in questions throughout the talk, and then at around 9:45 to 10, I will try to go through the questions and answer as many as I can. That's the format we're using. The update for this grand rounds is update on PTSD interventions in the Andes of Peru. I apparently neglected to get someone to introduce me, so I'll introduce myself. I'm a professor of clinical psychiatry here at the Semel Institute. I'm also director of the Inpatient Child and Adolescent Service. I've been medical director of some subsection of the Inpatient Child and Adolescent Service since 1987, and have been director of the whole Child and Adolescent Inpatient Service in 2006. I went to medical school at Stanford. I did my adult training in psychiatry at Yale. I came to UCLA to do my fellowship in child and adolescent psychiatry, and I've been here ever since. Other things I do besides running the inpatient service is, since 1989, I've been the psychiatric consultant for the maternal child immunology clinic here at UCLA, dealing with mothers and children who are HIV infected. The other thing I've been doing for the last 10 years has been doing international psychiatry in the Andes of Peru. With it kind of morphing over time into really focusing on PTSD around the civil war that happened in Peru from about 1980 to about 1996 between the government and a group called the Sendero Luminosa, or the Shining Path. This is a very personal and important kind of work that I've done, and kind of in an interesting way, where trauma and PTSD comes together. It's taken me a number of years to understand why I'm doing this work, and what has motivated me to kind of take up this kind of daunting task of working with Quechua Indian individuals in the remote areas of the Andes. There's a personal history of my family being exposed to genocide, with my grandmother, maternal grandmother, surviving and coming to this country, which has always made a strong impression on me. And then I've been kind of interested in this war that happened in Peru for since its inception. The Sendero Luminosa was a Maoist communist guerrilla group that was started by professors at the University of Ayacucho. Ayacucho is a city in the Andes that has a very large indigenous population of Quechuas. I think it's the largest city that has a Quechua population in Peru. And the professors there started this movement, which was initially tied to addressing the severe discrimination and mistreatment of the Quechua people by the Peruvian government throughout the Andean area, and a big issue of land seizures, where the Peruvians wanted to seize sacred land to actually build an international airport and hotel complex near Machu Picchu to increase tourism in the area. And it was over sacred burial grounds and land of the Quechua people. So this became the rallying cry of the Sendero Luminosa. And initially they were very successful in thwarting the army and really advocating for Quechua people's rights. But unfortunately, after about a couple years, it really devolved into a war where the Sendero Luminosa and the government, in a kind of very tragic way, created large armies that fought each other throughout Peru. And the Sendero Luminosa clearly lost their ideals and became intimately involved in cocaine production and distribution, somewhat like the FARC, which also, in a kind of paradoxical way, that challenged also the Peruvian army, which is very involved in cocaine distribution in Peru and outside of Peru. And so there became a battle over the cocaine trade and a battle over who would be militarily dominant in Peru. The tragedy for the Quechua people, where the ideals of fighting against discrimination, the Quechua people seemed to be put on the back burner. Unfortunately, both sides the people who ran the Sendero and who ran the Peruvian army were actually Peruvians, meaning people of European descent on both sides, but all the soldiers were Quechua, and both sides forced Quechua men to become soldiers. Otherwise, them or their families would be killed, because they said they were really traitors for the other side. And so there was a mobilization of vast numbers of young men throughout the Andean area, primarily in this area of Ayacucho, to create armies that fought each other in a merciless, bloody battles that actually took over small towns and executed huge numbers of indigenous people. And this went on for about 1982 to about 1996, where the Sendero finally were defeated, their leaders were captured or killed and put in jail, in paradoxically the same jail that the then-time president of Peru was eventually put in due to corruption and crimes against humanity about the killing of so many people in Peru. This war was incredibly destructive to the Quechua people in Peru. A lot of towns were devastated. Huge numbers of people were killed. in this area of Ayacucho, 175,000 individuals disappeared, and in the last 5 years, they've been discovering their graves in mass graves, which is added to the trauma of exhuming individuals who are still in their clothes and they can be identified, adding to more trauma with the huge loss of people. So I, 10 years ago, decided to be part of a medical mission that goes to Ayacucho through the Peruvian American Medical Society, which is primarily an organization of physicians who were trained, did their medical training in Peru, have come to this country and decided to give back to Peru by doing volunteer medical work. Initially, in this area of Ayacucho, in 1996, when this mission first started coming to Ayacucho, the city was really devastated. There were very little access to medical care. There were children wandering the streets in kind of gangs because they were orphans as their parents had been killed. It was fairly chaotic, and this medical mission started to organize primary care treatment and surgical treatment. There is a state hospital in the city, and they would do surgical treatment for various medical conditions that were not available to the people of the city. And this went on in about a yearly mission for since 1996. About 10 years ago in 2010, I was asked to come because there became interest in expanding the primary care treatment of patients who are primarily Indigenous Quechua people. And they wanted to have an integrated healthcare kind of clinic that included pediatrics, internal medicine, family medicine, and psychiatry. And so I was asked to be there to do psychiatry, evaluations and triage in the city. And so I would see patients from ages 4 to 90 years old with a variety of different psychiatric issues. I would evaluate them and try to get those that needed more continued treatment. I tried to get them triaged to various different psychiatric interventions. And actually, Yale University or medical school had been interested in this area around the time I was there and had helped develop a mental health clinic in the main town, which could provide continuity of care for patients that I assessed. About 5 years ago, and in going back, so for the first 5 years of going there, there was these were people who came to the main city of Ayacucho, and they actually came usually for medical care, and then in the triage clinic, those that were deemed to have psychiatric issues were triaged to me. There was a range, the patients presented with a range of issues from autism, ADD, learning disabilities, schizophrenia, bipolar, major depression, sexual abuse, domestic violence victims, and it seemed like a remarkable similar group of people that you could see kind of anywhere. It's very interesting, but the Quechua people in general see psychiatric illness as a medical illness. So they see schizophrenia, bipolar, major depression as a medical illness. They don't appear to have a barrier about believing that it's medical. They quite embrace the concepts and in general are very cooperative with treatment for kind of those major psychiatric illnesses, and including developmental disabilities. So in a way, it was surprisingly easier to diagnose and work with patients and their families because they readily embraced Western notions of mental illness for whatever reason. It's always been kind of a surprise to me that they do that, but they do. About 5 years ago, the mission changed, and it was felt that Ayacucho was doing well enough that the access to medical and actually to mental health care had improved dramatically. There started universal health care in Peru, and while the universal health care didn't reach to kind of remote villages as robustly as it did in major cities, in the city of Ayacucho, there started becoming quite a bit more clinics and treatment access for all people in the region, so that it felt like, it started beginning to feel like that what we were doing there was redundant. So what happened is the mission split between two groups. One group were people who were surgeons and plastic surgeons who stayed in the main medical center to do surgical treatment. There's a high incidence in the Andes of cleft palate, and there's no access for these people to get cleft palate repaired. So there became a shift to really work as much as they can for a number of different Andean areas to actually fly patients to Ayacucho and to do cleft palate repair. And then other surgical procedures were also done. And then the other group, which was the integrated primary care group, it was decided that they would not work in Ayacucho anymore, but go to more remote villages outside of Ayacucho, where still access to mental health and medical care was meager, if barely existent. For various political and other reasons, even though there was universal health care in Peru, like everything in Peru, the implementation of some of these initiatives falls short for a number of reasons, which are too complicated, I think, to go into right now. So in every small town, there was supposed to be medical clinics called postas, but it took a number of years later for those to actually materialize. So we would go to small towns outside of Ayacucho, usually 2 to 3 hours away, on small roads, and had, again, with a team of pediatricians, internal medicine, family medicine. Sometimes we had dentists, and a mental health group consisting of myself, a psychiatric social worker, and other volunteers. I sometimes had child fellows come with me. There would be medical students that would come, and other volunteers that were interested into mental health issues. What became apparent when I was in these small villages is the focus of what we were dealing with psychiatrically suddenly became quite different. Again, the clinic was set up in a very similar way it was in the main town, but most of the patients, and I also saw patients from 4-year-old to 90 years old, but the majority of patients I saw all of a sudden shifted to much more people in their middle age or older who came in with a complaint of headaches or pain over my whole body. And after a triage evaluation, it was clear that this had something to do with psychiatry. And so I would evaluate these patients, and almost all of them talked about, initially, which seems to be the way of the Quechua, is they will talk about that I have headaches and pain all over my whole body. And then if you shift the conversation to, and I can't sleep. So these kind of very somatic complaints. And if you shift the conversation to, do you have any worries or preoccupations? Then it suddenly shifts to a whole different narrative. And the narrative that would come out exclusively was classic PTSD symptoms from the war. And it was, I would have people discuss flashbacks and memories of just horrific violence that they witnessed, and horrific. So, I mean, so disturbing that the translators, there were Quechua translators, would break down and cry. Some of the medical students, other people I was working with, had a very hard time tolerating what was being said. It was pretty disturbing, and almost every patient had these very similar stories where they were, and a lot of it was very personal, where they witnessed family members being tortured, mutilated, raped, and killed in front of them, and they were left to survive kind of as a terrorist move to make these small towns into submission. And who was doing it was both sides of the army and the Sendero, and it was, and these people had never spoken about these issues. And also what became apparent in these villages is this huge rate of alcoholism and alcohol abuse of males, and a significant rate of domestic violence. And if you looked at the people who were, and actually the men doing this rarely came to our clinic. it was always the wives or other female family members that would come. But if you ask the age of the men, they all look like they were the age in their early 20s during this war. And the assumption is that they were all soldiers on one side or the other during this this war, and whether they had overt PTSD is they weren't coming in, but it seemed like their alcohol abuse and domestic violence was really related to consequences of living during the time of the Civil War, and likely related to them being actually soldiers from one side or the other. That was information that was hard to get because it was very sensitive, because what the government and the Sendero did is often came to different towns and divided the towns in half. And half the male inhabitants would become government soldiers and half would become Sendero soldiers. And then the survivors all came back to the same town and they were fighting each other, and now they were living together. And there was a lot of tension in these towns, suspicion, hatred of neighbors that really had wrecked the cohesiveness of villages that for thousands of years had been very communal in a lot of in terms of religious rituals, cultural rituals, working together for harvests. They were really fractured and kind of paralyzed. So my job was to identify people who had post-traumatic stress disorder and then refer them, unfortunately, to the clinics in the main city of Ayacucho, which surprisingly, from getting feedback from the clinics, because I wrote up evaluations and I would follow through from the next year, there was about a 50% rate of people actually going to the clinics and receiving treatment, which is to me remarkable, because this is the cost of the transportation is very inexpensive, but it's like a 2 to 3 hour bus ride to get to these clinics and back. And the biggest problem is they can't work for a day in the field. And that was what seemingly most people were concerned about in going to get mental health care in the main town, was not being able to work on their farms for a day. But about 50% of the people I evaluated actually did go and get treatment for PTSD. They had a clinic with psychologists and other mental health workers who used cognitive behavioral work. There also was interventions for people with alcohol issues. And it seemed to work very well for a number of years. The last year I went to Peru, actually had an opportunity to do another level and actually a very interesting level of help facilitate a very interesting level of treatment. One thing I one thing that makes this successful is that they're in these remote villages. In one large area of them, there is a Quechua woman who's a nurse, who also is a spiritual leader among the people in that region. And she is very attuned to the psychiatric needs of the indigenous people, And actually, the month before we come, she goes on the radio, which is a main way of communication in this area for individuals, to explain in Quechua that this mission will be coming and that they can talk about issues that preoccupy them and psychiatric issues, and that she recommends everyone comes and sees the psychiatric team. She wanted to do be involved in a different level of intervention in some of these towns because she was concerned that that there are many people who are unable to go to Ayacucho who are really suffering, and that is there a model of a different kind of intervention. And at the same, and so we, Raquel is her name, and I met with psychologists, a group of psychologists, women psychologists in the main town of Ayacucho, who were willing to go out to small villages who had been really impacted by the war and do treatments directly in the villages, spending about a month in a couple of villages at a time. I, with the Pam's mission, was able to secure some financing to help pay for them to go out. So this was something that I didn't go myself, but I got reports from what they did. And what they did was very interesting. It was about 3 psychologists who would go out to communities that were severely impacted by the war. And what a lot of these communities were very fractured. It was kind of walking in from talking to these psychologists. It was kind of walking into one large PTSD world. There are, part of the issue was, again, because a lot of these communities were divided and neighbors fought against neighbors in this war. There was an incredible lack of community cohesion. There were suspicions about neighbors and a lack of cooperativeness with each other. There was a lack of respect for the community leaders, like the mayors of the town, because everyone was felt to be on one side or the other, or collaborators on one side or the other. And so the efficiency and kind of government management of the towns had deteriorated. Also, there was this issue of alcohol abuse and severe domestic violence. And also, according to these psychologists, really poor parenting. In other words, it seemed like adults they became very passive-like, and their children were either treated in a very strict, physically abusive way, or the parents were very overly permissive. And it's like they had forgotten how to parent. And a lot of this was the disruption of family, lost generations of grandparents and parents who had been disappeared or executed during the war. And so a lot of the normal parenting skills were just absent. And also the quality of education and commitment to education for the what was focused on was the adolescents seemed to also had withered. And people dropped out of school, they didn't finish high school, and it seemed like the schools were kind of disorganized. And so they actually did a very interesting thing, is to went to these villages, were able to organize meetings of everybody in the village, usually in a large soccer arena, which is there, and started to break up different groups to really using a group educational approach to work with parents on appropriate parenting. And the model they used was called friendly and firm, that you have to be friendly to your children, but firm with them. They worked with the kind of the mayors or the leaders about how they can be more assertive and organized in their leadership and deal with conflict resolution better. And again, it was done in a group setting with a lot of role-playing exercises. They worked with the teachers to help work with them how to create an appropriate learning environment for the adolescents. So kind of 9th grade to 12th grade was what their target, student target audience and the teachers for those grades, to inspire kids to stay in school, to learn how to discipline and keep the high schools, keep kids going to school and being appropriate behaviorally in the classroom while maximizing learning. And then they also did a lot of group work between adolescents and parents, where they did these, where they had people write out on these big poster boards kind of ideals of what they wanted from their parents, and the parents wrote about ideals of what they wanted for their children. And they kind of had the group of parents separate and the group of adolescents separate, and then they came together and expressed what their critiques and wishes were, and tried to do kind of repairing a lot of the poor parenting that was perceived to be going on. And this was done in large group settings, like 100 people, even though they broke them up into smaller groups. And it seemed to be remarkably successful. And it kind of broke the spell of the insecurity, demoralization, despair, sadness, and hatred that had taken over these towns and made them really dysfunctional, with a couple week intervention. I mean, the caveat is that these psychologists were fluent in Quechua. So all of this was done in Quechua, not Spanish. And in a lot of these villages, people have minimal Spanish skills. So it has to be done in Quechua. So what I think made this so effective is that that they had Quechua-speaking psychologists who could do these group and cognitive techniques. And just being able to speak Quechua while they're doing it obviously increases interest, compliance, and engagement. And it's a challenge because there aren't a lot of people in Peru who are trained as psychologists or mental health workers that actually can be fluent in Quechua, because it isn't that you can't just speak it, you have to be fluent in it. unfortunately, in June of 2020, I was planning to work with these psychologists and go in these towns due to the success in 2019 of their interventions, and also work on securing more money to help pay for these interventions. And I had a child fellow, second-year child fellow, all ready to go with me. We had a whole team going, and then COVID struck. And unfortunately, Peru is one of the most affected countries in the world with COVID per capita. And actually how bad it is not really clear, because especially in the Andean areas, the communication is poor. But from people I know who communicate with people in the Andean areas from this organization, it is devastating. There's no medical services. Basically, the medical services are a posta, and they have one area for childbirth. And that's the only kind of medical service there is childbirth. There are no ventilators. There's no ICUs. And so people are dying in the streets. It's a little hard to know exactly what's going on because Peru has kind of shut down the country completely. And unfortunately, in doing that and tourism drying up, a lot of the indigenous people who were living in Peru and other large cities went back to their Andean mountain homes, and they carried COVID with them and infected large areas of the Andes with really no appropriate medical care to treat people. And it apparently, from the fragmented things I've heard for some people who have been to some of these areas, again, their bodies in the streets, people, it's really devastating. Unfortunately, I had to cancel the mission this last June because no one was going to Peru. And if you got there, you weren't coming out. And so sadly, really seeing how this firsthand, how this kind of, this intervention in these small towns by these psychologists and how it was working firsthand and participating in it has been lost. And I don't, and the question of when one can go back to help do this work is not clear. And I don't know if I'll be able to go back this next year. We'll just have to see. But it is impressive. This war ended in 1996, yet the devastation to these Andean communities is like the war ended yesterday. And we're talking about decades later, but it's amazing how there is a multi-generational horrific effect of the trauma of war that these individuals have not been able to recover with. And the idea of really kind of moving to doing interventions in the villages where they live seems to probably be the most robust and efficient way of trying to repair the trauma that's occurred to these individuals. And we'll have to see how it works in the future, and we'll have to see if COVID can be controlled so we can go back there to continue our work. Thank you very much. I'm going to try to answer some questions at this point. Let's see. Let's see how we're going to do this. So there's a question saying, are there indigenous healing practices in the villages complementing psychiatric intervention, or do villagers choose between indigenous practices or medical practices or no intervention? And how do wives convince their husbands to receive treatment given the barriers, internal and external? There are indigenous healing practices and they do work complementary with medical and psychiatric treatment. As I was saying earlier, kind of interestingly, kind of for major psychiatric issues like schizophrenia, psychotic mood disorders, major depression, they see those as medical problems. And unfortunately, often what seems to happen in these smaller villages is if the people especially are behaviorally very disruptive, they're basically excluded from the community. Some are kept in homes and kind of isolated from the community, but there's they see this as a medical problem, and they feel the community can't support people with these severe issues. And so they tend to kind of migrate down eventually to the large city, and there's kind of a homeless population of chronically mentally ill in the main city. Wives have a hard time convincing their abusive alcoholic parents, spouses to stop drinking. There have been developed some domestic violence programs in these areas that just focus on domestic violence. And mostly what they're doing is separating the abusive, usually man, from the family, and trying to get support and trying to get the woman and children to live in a different place so they're not exposed to the person. There are the only that I have seen really treatment for alcoholism is in the main city of Ayacucho. And so it takes a highly motivated individual to go there to get treatment. And the interventions are more separation. Next question is, are there any attempt at a truth and reconciliation process in Peru? I mean, in a way, it's just starting now. About 2 years ago, the Peruvian government officially stated that there was post-traumatic stress disorder due to the conflict. Unfortunately, the initial reaction to the end of the war was it's really important to forget about the war. And so there became this incredible amnesia of the Peruvian people over what happened. And the bad actors were put in jail, it's over. And they really focused on not thinking about it and minimizing the whole conflict, even though it convulsed the country for about 15 to 16 years. It's kind of remarkable. In about the last 2 to 3 years, there has been an official acknowledgement that people have PTSD from the war, and there have been government funds for mental health clinics to be developed in major cities like the city of Ayacucho, but not outreach to the smaller towns and villages affected. The truth and reconciliation process never happened because their point of view was forget about it. And the bad actors, the heads of they took more a punishment process that actually the president of Peru, Fujimori, and the heads of the Sendero were all put in jail. And that was truth and reconciliation. And let's forget about the whole thing. So unfortunately, it hasn't been done. It certainly hasn't been done in the Andean areas where the war was actually primarily fought, though actually it was in the cities too. It was in Lima, but not to the same degree. Kate Sheehan says, let's see, what is the name of the parent adolescent group program? Has it been used with other populations? The name The psychologists who do it have a name called Sayri, Sayri. And Kate, if you're really interested, I can try to get you their information. I have it here somewhere. This doesn't jump out at me. But if you want to email me, I can give you more specific information about them. And I don't know if it's been used in other populations facing intergenerational trauma. I mean, talking to these psychologists, they felt that this was the best this kind of group approach and kind of role-playing approach and kind of felt culturally what the Quechua people could accept and would engage them. So it was specifically designed for this population. That doesn't mean it couldn't be used for other populations, but they had really thought through that this would be what would be most acceptable for this population, especially dealing with communities who are very suspicious of outsiders, have been traumatized by outsiders, and anyone who seems official, who looks Peruvian, there's a big barrier in terms of being comfortable, being honest with them. So they thought that this was the best way to work for this community. And how applicable it is to others, it probably is, but it was really designed for this community. So that's my, let's see. There's a question of how do religious beliefs interact with the interventions? They do. It's very interesting, but what makes the interventions work when I have been there is this woman, Raquel, who's a nurse and also is a spiritual leader. When we come, a prayer is done in Quechua, and they sing a song to us. And they bless the gods, and they bless the community. So from the get-go of every day that we're there, we're kind of blessed by their religious beliefs and cultural beliefs. And again, they remarkably don't seem, they can hold two concepts together at the same time. They can accept Western medicine, and it doesn't seem to challenge their own religious cultural beliefs. Now, do I really know that? I don't really know that because I don't speak Quechua, okay? And everyone is incredibly polite to me, and they call me Papa, and they kiss me on the cheek, and they're very, very nice. And they're very cooperative with me. The only way I kind of really get this is this woman, this spiritual leader nurse, Raquel, is the one who tells me this works. And that the blending of their beliefs and kind of a Western viewpoint of mental health isn't incongruent, and they seem to be able to reconcile both together. Especially especially with the devastation of the trauma of this war, these people are looking for interventions to help them. But every interaction begins with a prayer, and it ends with a prayer at the end when we leave, and there's a lot of thank you and little presents are given, and we often eat a meal together. So there is a ritual that brings in their cultural world and their religious world. And again, it's all in Quechua, so I kind of understand what they're talking about, but I really don't understand what they're talking about. Okay. There's a question about what about Peruvian psychologists and psychiatrists' involvement with treatment in these areas? Good question. For whatever reason, there really is a split in Peru where many Peruvians, which are people of primarily European ancestry or identify themselves as people with European ancestry, really don't, the most polite thing I can say, have a lot of curiosity about dealing with the Quechua at all. They would prefer if they went away. They don't see any positive aspect to them. And they live far away in the mountains, and there's a remarkable lack of curiosity. The only thing that Peruvians think of in general about the Andes is Machu Picchu and how it brings so much tourism money to them. But the rest of the Andean world, they're not very curious about. It is very hard to get psychiatrists, Peruvian psychiatrists, to be involved in these communities. They don't want to be. That's the best answer why. And also psychologists. This one group that's in Ayacucho of these 3 women is the only group I've ever heard of that really is motivated and interested. They're psychologists that are from Ayacucho, they're fluent in Quechua, which is also unique. Most Peruvians do not speak Quechua, and they have no interest in learning to speak Quechua, but this one group of psychologists is. So there's very little mental health intervention coming from Peruvian physicians or mental health workers. There's a question here. Any sense on what aspects of the community and culture supported, or culture or individuals supported patients accessing and staying in care? I'm surprised, amazed that so many people presented for help and pursued treatment, especially considering how much avoidance is symptomatic of and usually interferes with PTSD treatment. I agree with you. I'm a little surprised too. I have not been able to do follow-up work because we shift to different communities with the people that are referred to the main clinic in Ayacucho. There's 50% who actually went. And so that's one kind of challenge. What I'm doing is that there isn't a year-by-year continuity. Again, I'm kind of reliant on this one woman, Raquel, who does keep track of things, who says it's very beneficial and people get benefit from it, but I can't state individual cases that I would that give me assurance that that's true, and I share this concern and skepticism. All I can say is this one nurse spiritual leader says that this is effective and she wants it to keep happening. And if she isn't involved, it doesn't happen. Because just walking into these communities and saying, hi, I'm from UCLA, I'm gonna help you with PTSD, is gonna go, people are just gonna laugh at you. It's gonna go nowhere. So there has to be some local authority endorsing what you're doing. And one of the downsides is that we move around to different places, and so I don't have the sense of continuity. See if there are other. Any other questions that if people have any other questions, I can stay a few more minutes. I hope, again, it is very hard to get international psychiatric, to be able to do international psychiatric work. A lot of places that want medical missions to come in, the level of crises that are going on doesn't, if you're looking at Haiti after the earthquakes, and in some other areas, people are dealing with such medical crises that a mental health component doesn't feel as relevant. You know, I think, you know, I think though there is a place for psychiatric missions, interventions, and I think one area is working on PTSD. There are a lot of places, sadly, in the world where there have been major conflicts that have involved the local populations with horrible traumatic experiences. There's stuff going on in the Congo and Western Equatorial Africa, you know, the Middle East, Syria, Lebanon, and other countries in the Middle East. What's going on to people in Afghanistan, Iraq, it's just horrific. And there isn't a lot of organized mental health interventions in these areas. But it's very hard to get it started. It's very hard to have buy-in from local governments and communities. And, you know, there are language barriers, there are cultural barriers. I feel very lucky that this has worked out as well as it has in Peru. On paper, people would say this would be, it took convincing. I thought it would be a waste of time, and it's become incredibly rewarding, incredibly challenging, and I really hope have been incredibly meaningful to the people touched by the interventions that I've helped coordinate. Anyway, thank you all for your attention. I've enjoyed talking about this, and again, if anyone wants to email me, I'm happy to talk in more detail about anything. If second-year fellows are interested in going to Peru, I just don't know what's going to happen this year. I think it's a second-year fellow issue. It's about a 2-week commitment. It's usually in June. I probably can take 1 fellow, maybe 2. But at the moment, no one's going to Peru. And I don't know when Peru will open up. And there's one issue about getting in there, and there's another issue about leaving and not being trapped there. And then there's a third issue about the control of pandemic and getting sick there. And so I think right now I'm not planning to go, but we'll have to see what can change in the next couple months. Thank you very much for your attention.